Hi there, this is Dr. Ang, and we are going to take a deep dive into neurological assessment. So, Neuro PowerPoint, you have it listed here, included on Harvey, and feel free to peruse that along with the resources that I have available for you there. And wanted to just give, kind of give an overview and then certain aspects that are going to be a little more important for you. We're going to take a deeper dive with that. Remember, I like to mention we're going to take the funnel effect. There's a lot of information regarding neuro that you're going to learn throughout the course of the program. But for sake of this course, we're going to kind of funnel all that information down into the more need to know information to help solidify a very solid foundation in neuro on which that we can build in future courses as you progress through the program. So, neuro assessment. And we will take off. Class learning outcomes here. As you can see, you can follow along with my PowerPoint. I'm not going to spend a lot of time on every slide. So if you are going through and you think we're not on the same PowerPoint, just click to the next slide and you should be able to follow along just fine there. And also, if you're going through your PowerPoint, you can also play mine and make notes if you see fit there as well. So class learning outcomes. We're going to discuss areas of assessment for the neuroregulatory submode, identify techniques to assess the following portions of the neurosystem, and you can see the areas there: cerebral, cranial nerves, cerebellum, sensory motor reflexes. We're going to hit all of these, differentiate normal from abnormal findings of the neurosystem, as well as describe the purpose and significance of nursing responsibilities related to neurological assessment. So when it comes to a neuro assessment, and we approach this from the aspect of a nurse, is a physical exam, and it consists of these following elements: motor, sensory, we have the autonomic aspects, as well as cognitive and behavioral. All this comprise the neuro assessment. And then begin by collecting information about neurofunctioning as soon as you encounter the client. So if a client comes into the emergency room or they come into a doctor's office, whatever the case may be, you're going to begin your neuro assessment from your first interaction. And that can be as simple as, are they comprehending what you're saying? Is there as you're communicating, are they comprehending that? You can assess their gait, the way they carry themselves in. Just initially, right when you meet them, you're already assessing without them even knowing that. So the neuro assessment does not have to be a long and extensive. A lot of it can be done before they even realize the assessment has taken place. Physical appearance and behaviors that we're going to be looking at. Emotions that are displayed. Is there a very flat affect? If you are engaging, do they seem to connect with you? Is there, not everyone is jolly and blissful about everything, so you're not necessarily looking for that. But you can see if in certain conditions too, there will be a very, very flat affect, regardless of what the conversation is about. Or is there a delay in response? Are they with a caregiver that seems to answer everything for them? These are all things you would want to make note of. Past history and current problems. Ineffective behaviors. So asking them what brings you in? What have you noticed any changes in behaviors? Regarding your health history, is there anything pertinent to the neuro system? Grooming and hygiene also can play a significant role. There can be the emotional side where they are somewhat checked out and there's less of an interest. There can also be the motor skill side where they are unable to do the things that they once did, the ADLs, activities of daily living. So you want to further dive into that. Their overall body language, including things that they say and things that they don't say. You're going to want to make note in your assessment. Levels of consciousness when we're looking at the assessment, neuro assessment. AVPU is a little acronym: alert, verbal, painful, or unresponsive. Those are all areas that we're wanting to look at. Cerebral functioning is mental status and speech. So you'll want to make note of that. Specifically, cerebral functioning is kind of the umbrella for mental status and overall speech and ability to communicate thoughts and feelings. Ability to answer questions appropriately falls under the cerebral functioning. And the level of consciousness, we want to determine, are they fully awake and alert and aware? Are they able to, do they know person, place, time, date? Questions that you ask them, are they able to respond appropriately? Do they seem confused? Are they appearing lethargic when they come in? Is there a state of delirium? And then stupor? And then it progresses all the way to coma. These are levels of consciousness and critical aspects of the neuro assessment. So family history, things that we're going to want to know, just think of it as we're trying to paint the big picture of the neuro assessment for the patient. So we need to know as many pieces to this puzzle as we can in order to get an accurate portrayal of their appropriate neuro status. So we want to determine relationship to client. So it makes a difference if it is a cousin's uncle or if it is a direct parent. So knowing relationship of first degree relationship to a patient, we want to ask about neurological diseases, hereditary aspects. How about alcoholism? Mental retardation or learning disorders can come into play. How about epilepsy, seizure disorders, even migraines? Alzheimer's disease and other forms of dementia, mental illness, a weakness or gait disorders, and metabolic disorders. These are all aspects that directly are impacted with the neurological system. So we want to ask about each of these. Personal and social history. There are specific to environmental or occupational hazards. Hand, eye, foot, dexterity, hand dominance. These are all things because when we're doing an in-depth neuro assessment, we obviously, if we're asking them to perform a task and we are offering to the left hand and the right hand dominant, that would make a difference. Different things, knowing what's specific to them, sleeping patterns, eating patterns. Just if they answer the questions for what it is now, we want to know, is this a change for you? Or is this how traditionally, is this common or is this uncommon? And that's what they're there for. We want to try to piece those aspects together and make special note of things that are recent changes in their neurological status. And sometimes some of these aspects, as I even cover them here, you may not even realize, and sure, a client with no medical background may not realize these are all components that can be indicative of neurological conditions or disorders. So asking these questions, whether they feel they're related or not, are going to maybe prompt some conversations that are going to help paint that picture of their neurological status. Drug, alcohol, and tobacco use. How long had they, or even if you ask them, we don't just ask them, do you consume alcohol or tobacco now? Are you currently? We want to know if they did for 40 years and now they've quit. So we want to take an extensive health history there. Prescription drugs and over-the-counter medications. What is normal? What is a typical day and week for this client regarding medications? And be sure visual, hearing, assistive aids are available if they're normally used. If you're trying to carry on an assessment and a conversation with a patient that normally wears a hearing aid and they don't have that device available and in use, that's not going to be a very reliable health history that you're taking, as well as glasses. If you're doing a neurological assessment, and there are certain tools that we use where they need to read something, and if you ask them to do that and they don't have their corrective lenses, that would not be produce reliable results as well. So making sure those are available. So also, when it regards to past medical history, we want to know the genetic side of things, the hereditary side of things, but we also want to know past medical history. Has there been a head or spine injury? Even when it comes to adolescence or college sports, were there a series of concussions, head injuries at that time, different things that you would even want to prompt examples that may spur important aspects that we need to include in their health history. Immunization status, have they had any surgeries, infectious diseases that may come into play, and then current neurological concerns, and some of these, as I mentioned, that you can make note of as well, such as if there is a tremor that may be visual that I would be able to see during an assessment, but maybe not. Maybe it's not present at that time, so another thing that you would want to ask. Gait coordination. When someone comes in and I encounter them for a neurological assessment, I may be able to see that there is some staggering with that gait or lack of coordination there. But another one that I would not be able to maybe visualize myself would be paresthesia or a numbness. That would be something that it is also subjective. I would not be able to totally assess that. So them letting me know, the client letting the nurse know how often do they have this. Is this something that's very common, or is this something that's rare, on a rare occurrence? And if so, what prompts that? Muscle weakness. Taking a full assessment of that, I can assess that, but I also want to get a health history from this patient. Is what prompted the muscle weakness? Does it come and go? Is it a consistent? And as well as pain. And pain is very subjective, but it is very real to that patient. So always assessing pain. And oftentimes, until we get that pain under control, we cannot further reach optimal outcomes. We have to get the pain under control, then we can assess things further. Cognitive functioning, again, level of consciousness. We hit this on a couple slides, but alert, confused, lethargic, delirium, stupor, and coma. That's the levels of consciousness that we want to be aware of. And to assess this using a standardized scale is what's going to be helpful. So for a neurological assessment, if I work day shift and I can grade or assess a certain level for a patient, but then if I hand off this patient to the night nurse, they may have a completely different view of that patient. So it's important we use a standardized tool, and one of those standardized tools that we have available for neurological assessments is the Glasgow Coma Scale, and that is GCS. So you'll see that, and I want you to look at that. I have examples on here just to make note of what exactly that we are assessing when we're using that scale, because that's an example of a neurological standardized scale when assessing the neural status for a patient. So when you look on to the next slide here, I have a little video that you can click on here and see an actual assessment of this being done. But you're scored, and you'll see on eye opening. I'm not going to read each of those. You can look at that motor response and then verbal response. You'll then give that client or that patient a score, and that's how you get their response rate basically. And then that elicits a standardized scale so that it can be true and accurate regardless of who's taking that. So how I remember it, this is the way I learn best, so I try to offer these. If these aren't helpful, then you can just click right through this. But how to remember the maximum number that is assigned to each part of the GCS scale. So for eyes, 4 eyes. If you're wearing glasses, you have 4 eyes, so the maximum level is 4. Verbal, think of the Jackson 5 singing. And if you see the pictures, this is going to make more sense. So looking at this slide 12. And then motor, so think of a 6-cylinder engine on a car, we have that. So that gives a total of 15. And each of these you're going to want to have, make note of this. If this makes sense to you, use it this way. Otherwise, just click back to the GCS scale and then you can memorize it however you want. But know that for eyes, response rate for eyes, it's 4 eyes if you're wearing glasses. Verbal, think of Jackson 5. So the total number that you can have, that section is 5. And then as far as motor response, and then think of the car with the 6 cylinders. So 4, 5, and then 6, and that equals a total of 15 for the GCS. Okay, cognitive functioning, orientation. So we want to know, and I'm going to be able to know this very quickly upon assessment. Orientation, person, place, time, and situation. You can find that out very quickly in a basic conversation. You may not even have to ask these specific ones, but you are going to be able to know if they know who they are, if they know where they are, what time it is, and then a specific situation or event that is going on. The next one is eliciting motor responses. This slide right here, I just want you to know the difference between the two posturings. And you can see that this is obviously an advanced stage in eliciting this motor response. So make note of this and the differences there. And I also have a visual for you. There's a second slide as well that shows a little bit closer up. And then pupil assessment. What are we looking for pupils? This is one that is very critical to neurological assessment to know how advanced, if there's debilitation, how far are we with that. So the acronym for that is PERLA. So P for pupils, E, that they're equal. So anything you're doing, if you have two, you need to compare both bilaterally. So even when we were talking about integumentary, if one arm seems warm, maybe that's true to them. But if you feel both arms bilaterally and you see one arm is warm but this arm is not, then you know based off of that assessment. The best thing to do is compare it bilaterally first. So P for pupils, E for equal, R is for round. The next R is for regular, L is for light, so reacts to light. And then A is accommodation, so estimate the size of pupils in millimeters. And I have an image on there which you can see the dilated pupil and then a constricted pupil. And when you see this, you will definitely know. So looking at that will kind of study so you'll know what you're looking for with regard to reactivity with pupils. Intellectual functioning, memory, attention, knowledge about condition, abstract thinking, association. This is a little more difficult unless you're taking a very, you need to know this just before you're having a conversation with someone. If you are having a conversation with someone that doesn't have past an 8th grade in school, did not go past the 8th grade or progress past that point, and then you're assessing them based off of what you're thinking, a typical person that graduated a 4-year degree in college, you may think that this individual is having complications related to neurological status, when really that is the norm for them, and that's okay. So knowing where they're at regarding knowledge, they may not know a lot about things that you think would be common knowledge. So that you need to study your audience first of all and know what would be a typical norm for that. And something that I always try to use is other people in the room. If someone else has come with this patient, you can ask them, have you noticed any changes? Especially if it's a child. Does Johnny seem, have there been any specific changes that concern you, that you have noticed? And then if they go into that, how long have you been noticing that? different things, let them kind of lead into that, because I don't know Johnny's norm. So that can be very helpful. You can also look in back health history to try to get a little bit of a recap, but you kind of try to figure out where that baseline is, so that you can build from there. Intellectual functioning as well these are things that are difficult to measure, but we do have some standardized tools in order to help us in doing that. But judgment, motor completion, emotional stability, speech, language, and again, as I mentioned, input from family and caregivers. Intellectual functioning, this is what I was just referencing. This is going to help with some of those that we said. How do we know where they're at with regards to some of those? Because it would be very difficult to assess. Therefore, we need a standardized test. And if you take a standardized test, it's almost like a pre-test, post-test. You'll administer it. You can administer it again and see, are they progressing? Are they degressing? Where are we at with that? So the MMSE is a mini mental state exam, and it's a standardized screening test. We're looking for a score greater than 26. And when we're in class, we give this to each other. And one thing that fascinates me about this is oftentimes if we don't take this, we don't know what our patients or our clients are experiencing. And this little exam is actually somewhat difficult or challenging, and many students will say, I feel it myself, things by counting backwards from 100 by 7. That's a difficult thing to do. That's not by any means something easy, that if I miss one, I must be suffering from severe neurological deficit. That is not the case. It's just taking through and seeing if they can try to process that information. Can they attempt to? And then you formulate the score. Some of them they'll breeze through. It'll be very, very easy for them. There are things that you trace, or you'll look at an object and then you take that away and then see if they can replicate that image that they saw. Just a very basic shapes or what have you, or being able to repeat 3 words that are repeated to them. Can they repeat those back to you? Objects, feeling an object in your hand that is, let's say, like a Hot Wheel car, putting that in their hand. Can they determine what that object is without seeing it? Things like that. But the score would be 26 or more would be desired. And then elderly adults. As with everything, there are certain things that just come with aging, and that does not mean that there is an acute reason for alarm related to neuro, but if there are certain things can kind of be precursors to let us know that we are suspecting maybe a mental illness or something that's coming, a neurological disorder, that it may be precursors to that, and we want to have be fully aware, because the most important thing is that patient is safe. And if we can put some parameters around and there's concerns, and we continue to watch and continue to monitor, but knowing what those are is critical. So requires special attention to subtle changes. Even if they think that this is not really a big deal, so I didn't mention it, I encourage them also, patients, to keep a log. Everyone's busy, and it's easy to write things off. Well, I did have that, or I did notice she did this, but I didn't think anything of it. But if you do suspect something, then encourage them to write a log, or keep a log or journal or something. And then when you come back for a revisit, then we can kind of look at that and see if there's been significant changes, and it can help monitor and provide the optimal outcomes for that patient. But again, the optimal outcome in the top priority is that patient is safe. So that will be driving the bus for interventions for that patient. Patterns of increased stumbling, falls, unsteadiness, we're going to want to make note of. Medications. Some medications, especially when we're referencing elderly adults, It's called a polypharmacy. That just is indicating that they're on significant amount of medications, and sometimes that conglomeration can lead to certain things, certain side effects that we need to find out. Is this specifically a neurological concern, or could this be a side effect of polypharmacy where there's just a lot of medications with a lot of side effects, and this is the result? So peeling back some of those would be a first line of defense. Changes in ADL and performance. They used to could comb their hair and fully dress, and now they're not able to, or they're not interested in doing so. There's some judgment or falling where they used to would go out and go for a walk by themselves, and now because of the cracks in the sidewalk or the stairs, or different things, they maybe don't do that. That's not the safest plan for them. Or when it comes to driving, not being able to see or interpret lights and distance and vision patterns. So now maybe driving after dark is not something that's in the top priority. Changing in ADLs and performance, that's that one. Sleeping patterns can also change. Social withdrawal, many times when things begin to become of concern, a lot of times it may have someone pull back. They're not as comfortable. I can't see as well. I can't hear as well. I don't feel I'm as stable. They have went to church every Sunday for 70 years, and now all of a sudden they don't want to go because they have an unsteady gait, or they fear different things, that it's just easier sometimes to recluse than to navigate that new norm for them. And that uncertainty can also, and if that's a point of social connection, then we want to give them the assisted devices that they need and the confidence and the reassurance they need to be able to do those things that they enjoy. Urinary or fecal incontinence, when it comes to this is another one that would make it where they may pull back and not do the things that they once loved. And it's also a difficult thing for caregivers then having to step into roles, and then the whole modesty and dignity and respect comes into play. And what does that look like for that patient when they're at home, or if they are in a assisted living care, long-term care facility, what that looks like when this maybe was someone that's used to being very independent and not having someone help, and sure not in that role. It can be difficult as they navigate that. Transient neurological deficits related to different things. Cardiac issues, stroke issues can all come into play for the elderly patients. Also, when it comes to children and neurological status, we're going to want to take a very deep dive into that pregnancy of that child. When that baby, before that baby was born, as well as the birthing process, and in that first year of life, a lot of neurological concerns are, red flags are raised during those times, and things specific to even the birth, and specifically related to mom, either choices that she made or hereditary implications, genetic conditions. All of those can come into play during pregnancy, birth, and then that year to up to 2 years, a lot of things can, those red flags that we want to be watching for. So asking questions about that. Something specifically would be the APGAR score. What was the APGAR score for your child when they are born? And then watching growth and development. What does that look like? Have they hit the milestones? Have they been behind on nearly every milestone? Are they seem to be catching up? How is their cognition? Are they where they should be, or are they lagging in that area? And reflexes is also another one. Are the primitive reflexes falling off? And then are they developing appropriately? So the confused patient, very important that we note the difference between delirium and dementia. Delirium, please make note of this, delirium is acute confused state. It's shorter temporary duration, and it often is associated to maybe a short bout in the ICU. Whereas dementia, it's not a disease itself, non-specific set of signs and symptoms, and it has a slow, deciduous onset. That's dementia. Delirium, again, is acute. So it comes on quicker, and it's temporary, and then say they're in the ICU, they have no idea what's going on, what day it is. You ask them their name, they don't recognize people coming in, and that can be very alarming to not only the patient, but to the family members that are experiencing this. And what a wonderful surprise it is then when they get out and then they can return because it was temporary. And that is delirium, acute, confused state, and then they can refer back to normal. But delirium, again, is more of a slow onset, and the symptoms must persist over 6 months in order to be dementia. But again, delirium, so that's a difference. Delirium, short, acute, and return to normal. Dementia, slow onset and lasts, the duration is over 6 months. So neurological examination goes deep into cranial nerves, cerebral function, sensory function, reflex testing. We're not going to take a really deep dive into this, but please be aware in general about these areas. Cranial nerves related to motor function, sensory function, parasympathetic functions. And you will see the cranial nerves on this slide. And you can see whether it's sympathetic, parasympathetic. You can see that listed. Let's see, I'm going to go in. So gross motor balance, this is something else that we're going to want to see. And a lot of these things you would think, this seems more like a motor skill type thing. This doesn't seem like a neurological assessment. When you think everything is controlled by the central nervous system, the brain and the spinal cord going down out into, is controlling our entire bodies. So when we have an issue with gait and balance, these are all aspects and part of our uniquely crafted brains. So bringing in that central nervous system and seeing if we're having a problem with balance, how is that affected by the neurological status of the CNS? So fine motor coordination, things such as taking a finger and bringing that and touching the nose. Seems like a relatively simple task, but if there is a neurological concern, it can be very hard, almost like if you're under the influence, and if you've ever seen a patient, friend, whoever with that, it can be kind of a difficult task, and you can see that, and you can, depending on the severity of that, it can be indicative of a neurological disturbance. There's also one, heel to shin. These are ones that I demonstrate if we're in class. You can do a quick Google search and see these, but the heel to shin, can they bring the heel and bring it up? Can they stand on one foot and close their eyes? The key to this one, if you have the patient stand up, lift one foot up, they can put the heel over on the shin of the planted foot, lift their arms out to the side. And when they close their eyes, the most important thing as the nurse when you're assessing this is that you stand close in case they lose their balance. More times than not, that happens. If you even do it yourself, you close your eyes, it's easy to get disoriented and to fall. And if you're not in a position, if the patient's not in a position to be able to catch themselves, you sure don't want them having an injury based off of that. But I have several fine motor assessments in children. Could be something as simple as stacking blocks. If they're not able to stack a block onto the other one because maybe it's a tremor or it's a Spatial issue that would be worth noting, buttons on something or picking up Cheerios and either eating them or putting them into a small bowl would be another one. So sensory also, this can be related to pain. This can be related to, we know from our bodies, if there's a spider on or something's hot or something's cold, that sends the message to our brain. Our brains interpret that, send the message back down of what action needs to be taken. So superficial touch, superficial pain, temperature, vibration, where we are in our relationship in space. Again, if you close your eyes, being able to have that perception of where you are, or if you're laying down and you sit up really quickly and you kind of get almost dizzy or disoriented, being able to close your eyes and knowing where you are. If I'm laying down, if I'm sitting up, what position I'm in, proportionate to space. Let's see, reflexes again. I have several on there. No, also, when it comes to conditions such as like meningitis and knowing the flexion of the head up and then the hips, and seeing what your body would do in that case, that's going to be one that I want you to definitely make note of. Now, these reflexes, you can go just generally knowing the deep tendon reflexes. I have them listed here on a slide. And then seeing how they are scored as well, so that there's a standardized scoring for reflexes, which meaning 0 is no response, referencing reflexes here, all the way up to 4+, which would be brisk, hyperactive with intermittent or transient clonus, okay, would be 4+. To perform positions, tap tendon briskly, compare corresponding sides. Again, bilaterally, we're going to see, are we having some weakness or affected on one side but not the other? We're not going to know unless we compare bilaterally, but knowing the difference between no response to 4+, and if we're hyperactive or brisk, or it goes into not only the response but then that clonus, or that shaking, almost like more of a tremor. Meningeal side, look at this side right here, and you want to see the Brudzinski sign. That's indicative of meningitis. And you look again, when the head is tilted forward, the hips will flex and the knees will come up. This is the cardinal sign of meningitis. Also a positive Koenig sign, and you can see with the knee and the foot when it's raised. The visual is going to be the most helpful for you here. Babinski sign, plantar reflex. And again, all of this, it's kind of fascinating to me. All these aspects have to do with the neurological assessment. Babinski sign, you can see that you take the stroking an object along the sole of the foot and bring it around, and you're going to watch the reaction of the toes. You can see it there. So rapid neurological assessment, I was telling you earlier in the PowerPoint, you want to be able to do this quickly. This is not something that should take you an hour and a half to do. You want to be able to move quickly and kind of get in a flow of what makes sense to you. I have a slide here about infant assessment. Again, what I was mentioning, in utero drug exposure, was that present? Multiple fetuses? Was this a twin or a triplet? Prenatal care, did the mother have prenatal care? If not, were there other things, health history, maybe there are holes in the health history that we don't know. Nutrition of the mother, birth history. Was there a traumatic delivery? Was the baby premature? Again, APGAR scores. Was there an infection? Did mom have an infection? Did baby have an infection? Was there a prolonged hospitalization? And if there was, why? Congenital abnormalities, and then developmental delays that maybe resulted from one of the above. We also, when we're talking about the GCS scale or the Glasgow-Coma scale, we also have a specific pediatric GCS, and we want to make note of that. Again, eye-opening, motor skills, and verbal responses. Sorry about that with my dog. Considerations when facilitating assessments of infants and children. You can look at the specifics were there. Again, I have several slides on reflexes. I just want you to be able to know that. Look at the lumbar puncture. Cerebral spinal fluid is drawn from between the vertebrae. You can see I have an image there for you to be able to see that. Don't worry about the scans in that. We'll get into that later in as you progress through the program. Hopefully that gives you a overview of neurological assessment on the part of the nurse. This is, again, just a very basic foundation that we will continue to build. If you have any questions or concerns related to any of this information, please reach out to me. I am more than happy to dive deeper with you. Take care.